Hi, everyone. Welcome to our lecture about the liver. Anyway, I'm just going to start my screen share here. Here we go. There we go. Hopefully you guys can all see that. Anyway, so this video is going to be about our main primary emunctory, which is the liver. It's considered the metabolizer. So it's the one that breaks stuff down and processes it. It does a lot of metabolic work. It's a pretty important organ. Obviously, you guys all know we can't live without it. So, what are we really going to talk about when it comes to liver? Not only is it important, but since it's the major metabolizer of toxins in the body, it also has a very high concentration of cytochrome P450 enzymes, which we're not going to get into like phase one and phase two and all that kind of stuff, but just know that it's a big part of this. Really, as people who work hands-on with the body, we want to look at how the liver palpates with respect to motility and mobility. So, what I mean by those words, motility is actually like the cranial sacral rhythm of the organ. So, each organ has a specific motion. It's considered to be an embryonic motion and it's very subtle, and we can actually discern a lot about the mechanics of the liver, etc., from that motion and what we need to address. The other thing we can look at is also the mobility. So looking at how mobile it is, whether there are tensions that are affecting the suspensory system, etc. And so really, because we come from a BGI perspective, we're going to look at, what we're looking at stored potential energy and how that may be impacting motility and mobility, but also to what is the quality of what's going on with the tissues? Is there a quality of that's associated with the stored toxins there? Is there a quality that we might notice in the tissues that's because of potential tissue changes from a disease progression, et cetera? So there's a lot of different information that we're going to look at when we cover the liver here. So liver, what are indicators? So when the liver feels like the lymph, sorry, feels very heavy and thick, that's a sign that we know that the liver's getting backed up. Just like what we see in congestive heart failure, where the heart is actually just not keeping up and the fluids are backing up in the lungs and the rest of the body. We're going to see that happen in the lymph. It's going to feel heavy and thick. And then swelling around the liver. You're going to notice that it just feels more swollen there. You're going to feel compared to the rib cage on the left side, just more fluids around that right rib cage, etc. Because there's liver on the left side, but not very much of it, and it only goes to the mid-clavicular line. And so complex patterns of tension may be layered into the suspensory ligaments of the liver. This is really apparent if there's been a history of whiplash, trauma, that kind of thing. One thing that we might notice is that people may complain of shoulder problems or hip problems. Strangely enough, that's a time to ask about the liver, because if there's a lot of stored potential in that liver, it actually creates a load where it pulls down on the shoulder or pulls the hip up into it, etc. So that's a really important thing to consider when you're seeing problems like that. And it's so great that we have the ability to palpate in the way that we do, because we're used to tracking out tension, et cetera, when we're looking for our self-fixation tracks. Another thing we're going to see in the liver is when it's stressed is areas of heat. We might see like really intense emotional patterns present in the person who's dealing with liver issues. Think of it as like, sometimes when it comes to emotions, we can regulate our emotions to a point, and then it's just really hard to do that. So think about it in terms of that. Like some of the emotional patterns really become clear when there's more stress on a system and more stress on the liver in particular. So the other thing we're going to see when the liver is stressed is that there may be a sense of congestion underneath the liver. So we're going to take a look at that. But there's a lot of circulation coming in and out of the liver. We have the arterial circulation underneath. We have portal vein coming in from underneath from the digestion, bringing all of those good nutrients from the food that we ate, but also some toxins to process. And we also have the biliary system, which is actually coming out underneath the liver into the gallbladder. But then venous drainage happens posteriorly and superiorly in the liver, just to the right of the spine. And a lot of times, I think most of us have probably noticed a little spot of tension there, kind of subdiaphragmatic, where there's tension, it's swelling in the ribs, and it's not really tracking out to any patterns. So you might find that bit of information handy, that that's probably congested venous drainage coming out of the liver. We may also see digestive sluggishness, like it's just the liver when it's backed up, like there's just a slowness to the whole system, it slows down. We might see digestive headaches. So when people are at certain stages in their digestion, they get headaches like a couple hours after they eat or something like that. We might see a coated tongue. So if we're actually looking at the tongue, we might see a coating on it rather than nice, healthy pink tongue. We might see a change in bowel habits when the liver is struggling. It might even go as bad as discoloration of the feces. It's really not good when that happens. Like, say, for example, if it turns white and floats. Another thing that we might want to look at the liver for is when somebody presents with allergies and hives. And a lot of thinking in naturopathic land and homotoxicology is to look to the liver and help the liver to help calm all of that down. And, really, when you think about it, probably almost all pathologies involve the liver to varying degrees. But the interesting thing is that in good health and in poor health, we can see issues here. And I like to think of it as a bit of a continuum where, when somebody is in full-on liver failure, think of that as like, okay, we've hit 100% decline in liver function. Most of us are probably not at 0% decline in liver function. We're probably somewhere between 20 and 50% or something like that. So, and what's really tricky is that really the liver can appear quite healthy in the blood work, et cetera, and still be struggling significantly. It can be, it really has to get down to probably or get to the 80% mark for things to really just stay elevated and be elevated. So when we're seeing changes in the blood work, we know we've actually come a long way along that continuum towards liver failure, et cetera. So think of it as playing like a central and crucial role in helping restore the health when you help the liver function better. So here's a few symptoms that are also associated with liver stress. So a few more indicators. Hormonal issues. I'm not going to get into it, but the liver processes the hormones, even cortisol, nightly hyperthermia. So between 2 and 4 a.m., just feeling really warm and maybe even sweaty. 4 a.m. is considered to be gallbladder. One of the things people might report is not necessarily pain, but a sense of heaviness in the right hypochondrium, chest wall, or the right side in general. Something people might notice is photophobia 1 to 2 hours after mealtime. So, of course, that's when you're going to have an increased load of toxins coming in from your food and things to process from your food. Facial swelling and flushing, it may be more pronounced on the right. Bilateral headache, often accompanied by neck pain. And one of the things that I like to just remind people is that liver has a structural element, but then it also has this very systemic element because it helps keep everything clean and processes all the toxins there. And then the kidneys are really responsible for removing it. So they're really a Batman and Robin kind of team. And then another thing we might see is chronic sinusitis, or a very sharp sense of smell. And the chronic sinusitis makes me think of the fact that one of the things that I've learned about the body is that it's going to try to get toxins out. And if it can't get it out the right way, or the best way, because there's just too much going on in those pathways, it's going to try and kick it out some other ways. And so chronic sinusitis is another way we can drain stuff out of our bodies. Sharp sense of smell. Again, notice that some of these symptoms that we've talked about already and will talk about are actually sensory systems. And so the sharp sense of smell reminds me of pregnancy and things like that, and our sense of taste changes. And I think part of it's actually to protect the infant in utero. Like when we're turned off by certain smells, we're going to avoid those things. And so that probably more sensitive to things when they just smell a little off, might be more of a load for the liver, etc. So it's actually a built-in protection mechanism for the body. Another thing that we might see is hypersensitivity of the eyeball, a sense of increased intraocular pressure, like you've got glaucoma, but really it's sort of like a pressure behind the eyes. I actually experienced this when I was taking a medication for a fungal infection. Those medications are very, very hard on the system and very hard on the liver. And I just kept feeling like my eyes were getting pushed out, and I got checked for glaucoma. I was fine, but that pressure was still there. And so in extreme cases, you're going to see like the eyes look like they're bulging a little bit. Hypersensitivity of the scalp. So again, a sensory system again. Minor disequilibrium and difficulty changing positions. So again, a sensory system, more associated with the vestibular system. There's a lot of fluids in the vestibular system. So, if everything's getting kind of heavy and thick, of course, this is going to affect the vestibular system as well. Vertigo that is more intense at certain times of the day. So somebody might actually find that their vertigo improves if they fast long enough to get to a point where they're in autophagy and doing cleanup in their body. So that is actually kind of an interesting symptom as well. Gritty tongue, acetonic breath, these are all signs of liver stress as well. Oily skin, greasy hair, hair loss. Another thing we might see is unrestorative sleep. So difficulty walking, morning tiredness that continues through the day. And really, actually, it kind of reminds me of a minor hangover. So maybe not a full-on hangover, but it's like you're just dealing with just that load of toxins that are really not getting processed. Another really common symptom people report when their liver is struggling is brain fog. And I liken it to really a mild encephalitis. So you're not in full-blown liver failure or anything like that, but the brain is foggy because, again, coming back to the lymph is going to feel heavy and thick. And we're probably dealing with some digestive issues where maybe there's more permeability of the gut than we'd like to see, which is loading the blood with more things for the liver to process. So really, I think there's stages when we're looking at something like true hepatic encephalopathy. And although this brain fog is really on the mild side, nowhere near the 100% liver failure side, it's still on that continuum there. Liver. So this is, we're going to hop into more structural things to understand about the liver. And one of the main things to understand is that it is a really heavy organ. It is 2 kilograms and it may contain 500 to 100 grams of blood. It will be very warm because it has a high internal temperature because of all the metabolic activity that it performs. The important thing here, though, is that from a mechanical standpoint, engineering standpoint, it doesn't make sense to have a 2 kilogram heavy organ at the top of a cavity. So really, nature has designed some ways to make it feel a lot less heavy. And so what we call that is its effective weight. So its effective weight should really actually only be 400 grams, not 2 kilograms. And so what we'll see is when the liver is more and more stressed in different ways, we're going to see that effective weight of the liver increase. So, we want to keep it at 400 grams. We don't want it to start feeling like it's 1 kilogram or 2 kilograms or anything like that. We want it to feel like it's nice and light. Kind of like the brain within the cranium. It's housed in fluids and it's almost weightless in those fluids. So the liver is not necessarily going to feel weightless, but we just want it to feel like it's suitable to be in its place at the top of a cavity like that. So when will the effective weight of the liver increase? It will increase if it's not in a balanced relationship with the diaphragm. Like it actually attaches to the diaphragm through some fascial connections, which we'll cover. But, if the diaphragm is really distorted or those ligaments have been stretched by something like a trauma or a whiplash, when we lose some of that elastic integrity of those tissues, etc., the effective weight of the liver can change and feel different. The effective weight of the liver can also increase if it's more congested, just because there's just more there. It's going to be actually physically heavier because it's congested. The other thing that can happen is that the liver can get fixed onto a neighboring structure. So as you can see in this picture, it's close to the stomach, etc. So when the liver actually gets there, when we lose the slide and the glide of the organs and they're stuck to each other or stuck to the walls of the cavity that they're in, this can create a problem with the effective weight and keeping it nice and light that way. And essentially, if the weight of the liver increases, if the effective weight of the liver increases, it can really actually become harmful. When you think about it, you don't want something that should feel like it's 400 grams feeling like it's 1.5 kilograms, because that's going to load some of those structures underneath it. And you even have important circulation coming out and in from underneath of it. So it can be quite harmful when that liver starts to get really heavy. So this picture here is from Netter, and I chose it because it has a really good description of the topographical anatomy and the liver's relationship with the lung and the heart. And so I like the way they've shadowed things here. So you can see the lung tissue, and then the pleura in blue. And so you can really see that long pleural drape, like the pleura actually really drapes the liver. But you can also see how the lungs actually are concave and the liver at the bottom on their inferior surface, and the liver sits right up into that with the diaphragm. And the diaphragm's a nice dome, etc., for the liver to work with. And so there's this snugging up of these tissues. And so you can really see how lung and liver can impact each other. And actually, one of the reasons why the liver's effective weight is 400 grams is that the lungs actually, because they're full of air and expand and contract, they actually have a negative pressure to them. So it's actually creating a suction to hold all of these organs up. And so we're going to see that suction decrease if the rib cage is really, really restricted and the lungs can't expand, either because the rib cage is very restricted or maybe the lungs are affected by some sort of disease. Another thing that might affect the liver is when you have a history of pneumonia or something like that, that can really affect those pleural recesses that are draping the liver. And so, this is something just to consider in terms of looking at the liver not as an isolated organ, but as something that's really interfacing with many other things. The other nice little thing that you can see in this picture is the liver's relationship to the heart. And the heart, you can see, doesn't interface with all of the liver, but it creates a little bit of depression in the liver. So that right side of the liver sits a little higher than it does in the middle and to the left, because the heart sits on it. So if the heart's effective weight increases for whatever reason, maybe the heart's enlarged, or maybe there's a lot of visceral fat stored around the heart, etc., that can really affect the pressure and the congestion of the liver. It can put a lot of pressure on it. So this next topic in regards to the structure of the liver is the falciform ligament. And the falciform ligament is a really important ligament. And one of the things about fascia that I think is really important to understand is that we give things names, but it doesn't mean the tissue stops and starts. It's not a different tissue necessarily. So this is where really understanding where tissue goes is important. So starting with the falciform ligament, it's, as you can see, a triangular ligament, and it's like most visceral suspensory elements, it's a peritoneal fold, which means it's like the two layers coming together. And oftentimes these layers will thicken and it does in this case. The falciform ligament is quite thick. If you ever cut up liver to cook for dinner or anything like that, there's often areas of the liver that are really easy to cut, and then you get to these really tough areas. And I don't like eating liver because of that texture change. I just don't like having that tough, like interspersed with softer tissues when I'm eating. But anyway, so as you can see, this falciform ligament divides the right and the left side of the liver, but then it comes anterior to the anterior abdominal wall. We're going to take a better look at that in a different picture. But it thickens in another area called the round ligament of the liver as well. It's not very well shown or characterized here. But essentially, it's also continuous with, you can see it kind of going up and over the liver to the right and to the left. And really, that's the coronary ligament. And then it thins out to just be Gleason's capsule, which is the capsule around the liver, etc. And so there's a lot of, you can see how the liver is attached through that structure there to the diaphragm. But then the interesting thing is that falciform ligament heads down the anterior abdominal wall along the median umbilical ligament specifically, like it just really connects into that particular thickening on the anterior abdominal wall. And it really impacts the balance of tensions in the abdomen. And just because it goes all the way down through that ligament and then covers the bladder, it then actually comes up the posterior aspect and coming right back up to that liver again. So it's one big loop. And so you've got to think of it as a very, the loop, I like to think of it as a reciprocal dynamic. So things can pull, if something's pulling down, it's maybe in the anterior aspect, it's pulling something up in the posterior aspect. So this is a dynamic to be thoughtful of when you're working with the liver. This picture here is a really great picture from Netter of the anterior abdominal wall. They've taken out the organs, so the liver's gone, but you can see the falciform ligament there up at the top. And if we palpate the falciform ligament on ourselves, just take a moment right now to find it. And we go up to, like, say, our xiphoid and lower sternum, and then just go to the right, just slightly. And right there, if you challenge the tissues, is your falciform ligament. And if you go further out from that, you will feel that you've gone too far. You don't have to go very far just to the right to hit that falciform ligament. And it then comes down the anterior abdominal wall, and very clearly here you can see it covering the bladder. And again, they've cut it. It does not mean the ligament is ended, but it goes up and back around again. So this is a really great picture to contemplate in terms of understanding just how much the liver can be playing a role in issues in other parts of the body as well. This is a great little picture I found online for demonstrating Glison's capsule. And basically the falciform ligament and the Glison's capsule are continuous. And the Glison's capsule actually goes down and invests the portal circulation coming into the liver. And so it's just another way that the tissue continues. One of the ways that the Glison's capsule is innervated is from the phrenic nerve. So coming from the cervicals is the phrenic nerve, and it goes through the celiac plexus to get to the Glison's capsule. And then also we have parasympathetic fibers from vagus nerve as well, and sympathetic fibers from the thoracic spine. So there's a lot of innervation here. And then we also have some lower intercostal nerves. So that if your people are actually reporting pain in the liver, etc., there's a lot of innervation there. So anterior surface of the liver, here we go. So again, you can see that falciform ligament dividing the right and left lobes. You can see it continuous up under the diaphragm, and you can really see how there's a ligament there, like that ligamentous connection to the diaphragm holding it up. And so that's really part of what gets stretched when we experience whiplash. And so those tissues can lose some of their elasticity and strength and be like overstretched when we have whiplash or traumas, that kind of thing. So the liver, since it's a very heavy organ, we know that force equals MA, so it has a lot of mass. So even when you compare it to the lung, which doesn't have that much mass, it moves a lot more and experiences a lot more force, and it can really stress all of these ligaments quite a bit. And one of the things that the osteopaths really note is that the left triangular ligament can be really quite restricted after a whiplash, and also the right as well, but the left especially. And so, and also the falciform, all of it can be stressed. But it's, so often when it comes to musculoskeletal things with regards to whiplash, et cetera, we're not very good at paying attention to how other things are affected by these stressors, like a whiplash or a trauma. And we are really, in our profession, I find concerned about how it's affecting the musculoskeletal systems, because that's really where people are reporting symptoms. But restoring the dynamics of all of these structures is actually also really important as well. So here's a nice picture of the inferior surface of the liver from Netter. And I really love this picture because you can see some of that circulation coming into the liver, and then how that is also really invested with the biliary system, where you have the biliary circulation emptying into the gallbladder there. Um, and one of the things that we see here is the inferior vena cava. And so we're going to have a better picture in the next slide here of that, where the inferior vena cava, if we look on the picture in the lower left, there's a bit of a dent there from the inferior vena cava, and you can see the veins draining into the inferior vena cava cut away. You can see the vein there. And so this is really the major venous drainage of the liver. And so the liver is a little bit different in that we typically see nerve, artery, vein bundles traveling through the body together. And in this case, the circulation's coming in from below and then exiting posteriorly and superiorly out of the liver. And again, this is an area where you might actually feel that little bit of extra congestion and pressure, and something that just doesn't quite track out there in that area, and can be, I know, has been a little bit frustrating to me as a chiropractor, and it's nice that I understand it now. But when you're looking at a very congested liver, one of the things that you want to do is also improve how well the veins can drain the blood in the liver. So we can, if you have good circulation coming in and poor circulation coming out, that's not great. So you really want to consider how blood's getting in and how blood's getting out when you're looking at a congested liver. Proper mechanics of the liver. Well, what does this require? I don't want to say it's just the liver, because it's not. So again, just considering the lungs and the pleura, we really want healthy lungs and pleura. We want those lungs to be able to expand and contract and glide and slide, have great negative pressure because they're super healthy. The pleura, again, needs to be able to glide and slide. It drapes over the liver. We don't want it stuck and very scar tissuey and fibrotic from maybe a past disease like pneumonia or something like that, where you get fluids into the pleura and some inflammation, and that can create that fibrosis between the layers there. We also want a very supple and tonic diaphragm. A lot of times in pediatric work, we're looking at the diaphragm a lot more than we are maybe in adults, but we really want good diaphragm function. We want it to be able to feel like the diaphragm can function really, really well, and it doesn't have a lot of distortion in it. So when you're looking at the diaphragm, really consider the fact that if it's not moving really well and in a balanced way, it's definitely going to be having an effect on the liver. The other thing we want to see is very nice extensible ligamentous attachments. Not too extensible like what we see if there's been a whiplash or anything like that, but we also just don't want things to be shortened and fibrotic and stuck as well. So then there's also the elasticity of the liver tissue itself. And so, there's a parenchyma feel to the liver. So I don't know if you guys remember that word from school, but we want there to be a nice elasticity to the parenchyma of the liver. The other thing we want to see is a correct subdiaphragmatic position of the liver. So we want to see that percussive dullness starts at the fourth or fifth intercostal space. I don't know if you guys remember from physical exam class, For us, it was in second year where you do percussion to really map out the liver and you can check for hepatomegaly, et cetera, and make sure that the liver's the right size, all that kind of stuff. And then there's also the elasticity of the hepatic blood vessels. So vascular health is really important. We want to have nice elastic vessels that can bring blood and oxygen to the region and also take it away so that there isn't congestion. So we want nice, healthy blood vessels. And then last but not least, we want a nice, healthy heart. As you can see in this picture, the heart sits on the liver more to the left side and kind of in the middle. But if the heart is actually enlarged, surrounded by a lot of visceral fat, or just really heavy itself, etc., and not very elastic, it actually creates a load on the liver from a structural standpoint and can really lead to some stagnation in those areas of the liver as well. This is a great little picture of how liver circulation works in the parenchyma. So of course we have portal circulation coming in from the digestion, bringing all the good stuff from our food and also some of the toxins. And then we also here have the hepatic artery bringing blood and oxygen to the liver. We have the green vessels are the biliary system, so draining into the gallbladder. And then you can see above the hepatic vein draining posteriorly and superiorly out of the liver. So we really want to see that feel really balanced so that the liver is less congested. So pathology of the liver. The reality is that uh, there's the change in the liver tissue, and then there's also the suspensory system. So those are two things we're kind of paying attention to when we're considering the liver. So when we look at what stresses the liver, this is really important. We need to understand this in terms of helping people make some changes in their lives or make better decisions, or just even understanding how these things that are even beyond their control affect their liver. So sources of stress for the liver are things like maybe extrahepatic tensions that pull the liver, and such as scar tissue or sclerosis. A really good example is appendectomy. So if somebody has a history of appendicitis, they have an appendectomy, it creates a scar tissue on that right side, and that can really pull on the liver. Recently, I had a client who has a history of tearing their quadriceps, and that actually really pulled their liver, even though it was inferior quadriceps close to the patellar tendon. It, from all the way there, it was pulling down on the liver. And toxic substances such as alcohol, drugs, food, environmental exposures. We're just exposed to so much these days. I could probably do a full-on lecture just on that. So just understand that there's a lot of things that we can be exposed to. And our goal here isn't to make you an expert on that, but just to understand a lot more about what's under your hands. Viral infections can really cause the liver to lose elasticity. And so oftentimes when it comes to viral infections, we might think of the family of viruses like the hepatitis viruses, etc. But there's, even dengue fever attacks the liver. Like all of the viruses that we experience can have impacts on our organs, and this can contribute to a loss of elasticity. And part of that might happen because of the death of the cells, and then we have fibrosis and maybe even fatty infiltration from that. That can happen as well. So again, next point then abnormal fibrosis of the hepatic tissues is a problem as well that can really restrict circulation, etc. And then we're just not really having great function of those cells. They're under tension and under stress, and there's probably less hepatocytes to do the work. So also to hypertrophy of the right ventricle of the heart can create a lot of heaviness and blood stagnation in the liver. Chronic cough can cause problems with the liver. Like that's a lot of force for the diaphragm and the liver to be going through. Bronchitis and asthma, again, things that impact our ability to breathe in and out really well and fully. When I like to think of breath as something that actually can help pump the liver. When we take a deep breath, the lungs are like actually pushing down on the liver and pumping it in a gentle way when we breathe in and out. So deep breath is good for more than just calming calming the nervous system and trying to help us get more into parasympathetic and sympathetic balance. So those conditions can really affect the liver as well. Depression can affect the liver. Partly because if we're in a state where our HPA axis is chronically activated and we're producing a lot of cortisol, that load of cortisol is actually something the liver has to process. We process that in the liver. Depression is also known to be also a state of inflammation. And so we see that low level inflammation impacting the liver as well. I always think of inflammation as kind of like resting and aging us. So the more we can minimize inflammation in the body, the better. It really has a big effect on things. And really, actually, the liver is now considered an immune organ in the sense that it actually processes inflammation in the body as well. And then also, too, um, there's a big connection between the gut, the brain, and the liver. And so that gut health, having healthy microbiota, making amazing compounds that are good for us, and then potentially having a leaky intestinal barrier, and that then affecting the load of things that the liver has to process in the blood, et cetera. Like it's just a cycle of things that affect each other, and it's like a stack of dominoes. Pregnancy and childbirth. So pregnancy also is a big hormonal change, structural change. All of those things are actually going to affect the liver as well. We see like increased insulin resistance, et cetera, in pregnancy. So there's a lot of changes with pregnancy that can impact the liver as well. And same with childbirth. It's a pretty stressful experience structurally, chemically. We'll often see a big, huge drop of hormones. It can actually also be, for some people, a very stressful experience to be caring for a newborn, not getting enough sleep and having that chronically activated HPA axis again. Sedentary lifestyle, again, probably because we're not pumping with the breath when we're very sedentary and giving the liver that chance to really have just that extra mechanical pump to help it with the congestion and move things along within the liver. And then too, a lot of times with a sedentary lifestyle, that there's a lot that happens when we exercise and move, and it's one of those things like there's just not a pill for it. So we really need to go and do that. The benefits are just so wide reaching. Occupational demands. Of course, for some people, they work in environments where there's a lot of toxins, maybe heavy metals, pesticides, all that kind of stuff. But I also feel like having sedentary work is an occupational demand that can affect the liver as well. Even for us as chiropractors, we're often bent over and twisted in weird positions. And in some ways, that might be pumping our liver, but our liver can also experience a little more compression from some of the positions we get in, and also maybe a few more forces from some of the things, the maneuvers that we do as chiropractors. Cirrhosis. So I'm not going to get too much into cirrhosis. These are diseases that I hope you don't see very much. Just know that we're going to see a reduction in hepatocytes. There's going to be more fibrosis. Vascularity is going to be less elastic and less effective. There's many causes for biliary cirrhosis. We'll go a little bit into that in the next page, but everything from hepatitis, Wilson's disease, chronic congestive heart failure, parasites like schistosomiasis, etc. But when it's very serious, like when it starts to get to the point where the liver is really failing, we're going to see things like jaundice, edema, ascites, disorders of coagulation, because actually all our coagulation products are made in the liver, portal hypotension, which will show up as hemorrhoids, esophageal and gastric varices, splenomegaly, encephalopathy, so that brain not working so good, and cachexia, loss of appetite, and weight loss. So I'm kind of hoping for the most part, we don't really see this in practice, but just know this is kind of going to like the, 80 to 90% failure situation here when you're dealing with these symptoms. So, cirrhosis can be caused by many different things, but we're probably very familiar with alcoholic cirrhosis. And then biliary cirrhosis, there's a few different kinds. One is primary, and basically we see disruption of bile excretion for different reasons. And the bile, when it accumulates, destroys your hepatocytes. So bile is very destructive. You do not want it in high concentrations anywhere. And so, one of the things that we'll see is like the stoppage of bile excretion in primary biliary cirrhosis. And actually, it's usually something we see in women. It's associated with female hormones, etc. Secondary is when we actually see something structurally obstructing the bile ducts, like gallstones, tumors, postoperative scar tissue, those kinds of things. And so really, when these things get bad enough, we start to see those symptoms like jaundice, hepatomegaly, dark urine, intense itching, diarrhea, floaty white poops, purpura, which is like bleeding out in the tissue, malabsorption of your lipid soluble vitamins. Like things are really serious when it gets to this point. And I really kind of hope this is not somebody that's starting out in your practice. But also, too, we see people where they may have dealt with these issues. I definitely have, where maybe a tumor was discovered because they were dealing with secondary biliary cirrhosis, et cetera, and all of these symptoms. And so it's just good to understand, what's happened here and why that might have happened. The other thing that we see is the lipid infiltration. And now they keep changing the name for when people start having a fatty liver. So I'm just going to call it lipid infiltration for the purposes of this. And, really, this kind of probably, I think, mainly comes from a sugar intake problem, unfortunately. Our diets are so high in sugar now, and half of the sugar out there, if, table sugar is fructose, and we have a lot of high fructose corn syrup in our food now. And fructose is not like glucose where we can just absorb it into our bloodstream. Insulin opens the doors to our cells and tucks it into the cells. Fructose actually has to go to the liver and be processed by the liver and turned into glucose. So this is why it has a lower glycemic index. That does not mean it's better for you. And so when you have too much fructose at once, so not in the context of like having fruit with fiber or something like that, it's really something then your liver has to deal with, and it can back up and cause damage. So in this case, you're going to start to feel like the liver's larger, firm, rubbery. We see it more often with obesity, but I see it in thin people as well. People come into my office with their scans and they have fatty liver and they're very thin. Alcoholism, we can see this happen, diabetes, ulcerative colitis, pancreatitis, cardiac insufficiency, hepatotoxicity. All of these things are situations where you might see a lot of lipid infiltration of the liver. I just want to say one thing about pancreatitis is that in the ducts coming from the gallbladder and the pancreas, those ducts might just insert directly into the intestine themselves. So they'll be independent, like close to each other when they empty the contents into the small intestine, but they're not connected. And then some people have anatomy where those ducts actually come together and connect and then go into the small intestine as one. And when that happens, coming back to, you do not want bile around. That bile, instead of heading into the intestine, if the pressures get off or there's some sort of inflammation or something blocking and that sphincter of Oddi's not opening, that bile can then go into the pancreas and cause pancreatitis and kill a lot of cells in the pancreas and leave people with like a type 1 diabetes from all of that destruction. I have a few people in my practice where this has happened to them, and it's very, very serious. So just keep that in mind. It's also very, very painful. So that would be your red flag that something's happening there. It's extremely painful. Okay. But probably the most important thing to remember is that the quality of the parenchymal tissue of the liver is going to feel different. And so, as you go about palpating people's livers and things like that, based on the information you have, you can go and feel things like motility and mobility. But a fun one to play with is a bit of recoil. So, what does it feel like when you compress the liver? And then let that compression off slowly or quickly or even recoil, like that can give you a little bit of an idea of what that parenchymal tissue feels like. And so when you know somebody has a healthy liver, have fun feeling that. When you know somebody has some of these issues or history of some of these issues, definitely take the time to play with the quality of that parenchymal tissue as well. And we'll get into working with tone with regards to that as well in the exercises associated with this particular organ. So a lot of these things here covered in gross palpation of the liver, I hope you never see. Probably the most likely one is going to be neoplasm. You probably will see some hemangiomas. You may or may not know about them, but it will change the quality of the tissue. And so hobnail liver, multiple small, closely spaced protrusions is an indicator of cirrhosis. I have never actually felt this. Um, if somebody with, cirrhosis comes in and that's happening, that's great. So you might feel like hardness and small protrusions, and that's really like nodular neoplasms. Definitely have seen this, especially with people who've had cancer that has become stage 4 and has spread to the liver. You might feel like it's covered in grooves, like a bundled like a roast, associated with syphilis. I have not seen this. Syphilis is not a common disease in Canada in terms of being able to spread in a way where it gets this bad. So, but just something to keep in mind. And then also round prominences that can shake on palpation are hydatid cysts. Never seen that, so that's kind of an interesting one to consider. Painful mobile prominences with fever, that can be infection. You might also feel a lot of heat with those. Like when there's infection there, you might feel a lot of heat. And I have to say I have seen that. Massive hardened hepatomegaly. When it just feels like the liver's like a brick or a big chunk of it's a brick, you're probably dealing with a primary hepatoma. Inhalation will be difficult. Like just you're going to find that when you're working with tracks through this area, it's like you really can't get through it. You can't establish continuity. I have seen a case like this and I didn't know what it was and I didn't know what it was. And then lo and behold, the person was diagnosed with a primary hepatoma and died within 4 weeks. So when you see this, you probably need to refer out so that it gets checked out. Hemangiomas, they are benign. They're no big deal, but they can change the quality of the tissue. A lot of times you may or may not know about this because it really comes up in more detailed imaging like CT or MRI, that kind of thing. But as you know from your radiology, they're no big deal, but we see them. And so now we're going to get a little bit into motility of the liver. And so this is that very subtle motion of the liver. And we're going to consider 3 different planes. So the first one we're going to look at is the sagittal plane. Now, this picture comes from a Barral textbook where they discuss motility, but I wish the arrow actually was double-ended because really what we see is a motion. So the sagittal plane is going to be like from like a rocking A to P. So we're looking at a slice through the body where you can see the kidney posteriorly there, and then anteriorly the abdominal wall and the ribs, etc. So, we have this like rocking from A to P, this motion from A to P of like the liver kind of turning, like actually it feels like it's just going along a little bit of an arc and then coming back again. And so this motion is just really subtle. And I want you to take the time right now to actually feel your own liver. So put your hands on that rib cage, try and get a nice broad contact. Maybe I'm going to feel from the front and I'm just going to get a sense of my liver and which way it's going. And right now I feel like it's moving posteriorly in that transverse plane. And I feel like I'm able to go back and it's slow. And now it's turning around and coming anterior. And I actually feel like it rushes a little bit, especially at the end, and then as it turns around again to go posterior, it kind of doesn't rush as much, like it's definitely slower to go posterior. So that kind of tells me there's a little bit of something pulling it anterior. And so here's the next plane, and this is motility, sorry, in the transverse plane. And so this one, again, I wish the arrow was double-ended because as much as it's the movement of the liver is maybe towards midline and that towards the midline, it also will move away from midline. Okay, so again, put your hands on your ribs. And so this is a very horizontal motion. And so it's just moving towards midline and then moving out. And just get a sense of like, is there a way that's easier? What are you noticing in terms of like, is there much motion at all? Um, or does it feel like you get pulled into one direction and then it's hard to go the other? And for me, I actually feel like it's being pulled again, maybe not to midline, but just like to the anterior aspect of the liver and then more towards midline as well in my own body. And then here's motility in the frontal plane. And motility in the frontal plane, I like this arrow. It's bidirectional, so that's good. It's a better arrow, if you ask me. But notice that it seems to be, the motion seems to be like the axis of the motion is from the left, at the left border of the liver, so mid-clavicular line on the left. And then it actually kind of will arc, but inferiorly, and then arc a little bit towards the medial, and then arc up again. And when I consider this motion in my own liver, so now I'm going to feel it in my own liver, I feel like it's no problem to go down, and I'm returning back up, but I feel like I bump up against something. Like I feel like it should go further, but I bump up against something. And so the reality is that I've had a lot of experience feeling livers, and so I know that it should go a little further. Like I felt it go a little bit further. I know I'm bumping up against some sort of tension. And that's where actually just taking the time, like to just listen to different people's livers as much as you can. Don't try to fix anything, just listen. What are you noticing? And we will do that a lot with our hands-on exercises in the workshop as well. So this here is when the resultant motion we will see when we combine all three of those motions. And so it's really actually kind of got a nice arc towards midline that goes inferiorly. And then again, this should be a bidirectional arrow, but then coming up and back again to where it came from. So there's just this really nice kind of like almost like rolling in at an inferior medial angle and then coming back again. And so just take the time. What does your resultant motion feel like in your liver? And as I get on my liver, okay, I'm going in and down, turning around, now coming back out and up. And that feels a little harder and slower going that way. I feel like I bump into that, something that felt like it was resisting that last plane of motion. There we go. So what are you noticing? And when it comes to motility, one of the things that we want to see, just like we see with the cranial sacral rhythm, the amount the cranial sacral rhythm expands and contracts can vary. Sometimes we come across somebody where there's like almost no motion. So goal number one, get some motion going again so that we can actually get some circulation through this cerebrospinal fluid. You might feel like oh, right side's like actually moving well and expanding well, but the left isn't. And then the right can't quite expand as much as it would like to. And so, when we have something release, some stored potential energy release on the left side, we see an improvement even on that right side because they work together. And it's the same when you're assessing motility and working with motility in the organs. You actually will see an improvement. You want to see an improvement in that overall motion, but also it has a very slow periodicity, but you want to see it have a nice amplitude. So we don't want a tiny amplitude. We want a nice full amplitude. And it takes a while to really learn what full amplitude looks like. And so we're going to spend some time with that in the workshop so that you hopefully by the end have a better idea. But it does take some time to develop this skill to palpate this and really know where you're at in terms of restoring motility in the organ that you're working with. Now, this picture I threw up, you guys are all familiar with this. This is our coronal geometry. One of the things that's always tricky about BGI pictures, etc., is that it's really hard to, our bodies have all these lovely kind of curves and shapes and volumes, etc., and the geometry doesn't quite fit it perfectly. But really, when you think about coronal motion in the body, that inferior costal coronal area there is where your liver is. And it's not this perfect like back and forth arc really when you feel it. Like if you were to just play with that arc on your own here, just play with that arc of motion in your own body, you can feel that actually like when you arc forward um with the ribs around number 6, you can feel that sort of like caving in medially. And then as you come back out, you've got a nice expansion in the ribs with that. So as you arc all of through that motion there, it's like you can feel that it's not quite like just anterior posterior. It's got a little bit of a curve to it. And what I find really interesting when I look at the motility of organs, it very much aligns with coronal geometry and the movement we see in the body with that plane. And so a simple example would be the uterus, because the uterus has a nice anterior posterior rock. It's probably at a level of about a coronal 4 in the pelvis. And as that rock happens, it's very much similar to the movement that we would see in that pelvic motion, especially for a structure that's so medial, right? The liver is much more lateral than the uterus would be. So we see a little bit of just a bit of a tweak in that motion. Here's a picture of our inferior costal plane. And yeah, if only it was as perfectly perfect as it looks in this picture, but it's got a little bit of a tweak to it. Anyway, so palpation-wise, what is your homework right now? You do not need to do this homework right now. I just want you to go out there and feel as many livers as you can. Just start noticing. You can play with that concept of compressing the liver and slowly releasing the tissue, or more quickly releasing the tissue, or recoiling, and just seeing what you notice about the parenchyma of the tissue with different types of livers that come in your office, especially when you have a bit of information about it. I just want to review that whiplash, trauma, that can really affect the liver, that can really affect the ligamentous suspensory systems and the tension there. If a whiplash is bad enough, we lose some of that elasticity in the tissues, so the liver can feel heavier. But then also too, sometimes what can happen is because of that trauma, we can have some inflammation, and those tissues actually, instead of becoming more extensible, become less extensible. So we'll see a range of things with trauma, but it's bad when you lose the extensibility. That's really not great when that happens. And this can affect, of course, all the vessels that come in because they're surrounded and invested by these same tissues, and affect the circulation in and out of the liver in all the ways. Toxins. They can cause the liver to feel boggy, like more congested and fluidy. They can cause the liver to feel rubbery. We're going to get into um, things like extracellular and cellular toxins and, exploring tone from that perspective. But really, actually, at the end of the day, we're BGI practitioners or using the BGI concepts, and we really want to know where's the potential the greatest? Like what planes are we working with? How is that impacting the tensions, affecting this organ? Um, how are the toxins expressing? What are the tone of those toxins? Um, does the greatest stored potential energy, is it within the liver or does it lead us away from the liver? So these are all things that I want you to just mentally start adding to your list of things that you're considering in your office. So, and this slide actually covers just some overarching patterns we're going to see with the liver. So I just wanted to make a summary of all of that. Of course, restrictions in the thoracic spine from T7 to 10 and the ribs associated with those vertebrae. We're going to see bilateral or even more right cervical tensions like C4-5, ribs 1 and thoracic 1. Those are our bases for not only the regular geometry, like the foundational geometry, but also for internal geometry. Glenohumeral periarthritis on the right side. So again, like if the liver is really, really storing a lot of potential energy and it's really loaded, it's going to pull on all of this stuff and actually kind of squeeze that humerus, squeeze that humerus into the joint there for the shoulder, and it's going to impact range of motion. It'll feel tighter, all of that kind of stuff. So, that's really something to consider when you're seeing that on that right side. I do find that, the twos internal geometry are very much helpful for working with this particular issue. Cranial and facial tensions are associated with the patterns within the liver. So we've got like right parietal, temporal, sphenoid bones, etc. The liver attaches also to the diaphragm and the pleura, and the pleura then attaches to ribs and cervicals, etc. So there's just ways that things pull all the way through the system. We actually cover that a lot in internal geometry, but just to kind of plant the seed for that. If we want to confirm hepatic involvement, we can play with something called inhibition, and we're going to talk a bit about this in the workshop because I really do feel like when we're working with people, like people come in, let's face it, they're really upset about their symptoms. And we really want them to know in many ways that we're listening to them. But we're also aware enough to know that we can't just chase symptoms. Like how many times have you treated a shoulder over and over again or like worked with a shoulder, I should say, and like it doesn't necessarily improve the symptoms a lot. And really, when we want to know if the liver is involved with that shoulder, we can do something where we actually correct the tension in the shoulder with a bit of pressure. It's like if the liver is rolling forward and there's a lot of tension with the liver going anterior, we can come in, put a little bit of pressure and push it just a little bit posterior. And with that, we can have the person test the range of motion before we do this, and then we put the pressure on and then test the range of motion in the shoulder, and it improves. And so it really helps people understand why you're working where you're working, even though it seems like it's nowhere close to their area of symptoms. And so I do find that inhibition can be a great tool for communication. We often teach in chiropractic that we don't want you chasing symptoms. You've got to work with what you find. And this really just helps reiterate that to the person so that they understand that they are heard. We're not ignoring them. We just want to actually work. We want to work with we want to work in the most. We want to work with where the potential energy is the greatest. That's the bottom line. We're going to get changes that actually work for the system and symptoms. can resolve like when we get a 10% change, or they can resolve when we get an 80% change. So, it's one of those things, it's hard to say what will have the biggest impact for the body in terms of that and those kinds of things. The other thing I want you to work with is also monitoring diaphragm movement. Take some time to palpate it. What are you feeling at the diaphragm? Are you noticing more excursion with the breath on the left side versus the right, etc.? Just pay attention. And then last but not least, I want you to take some time, maybe even before people lie down on the table, because this is really something you need to do with gravity. I want you to consider the effective weight of the liver. Does it feel like it's 400 grams, or does it feel like it might be 1.5 kilograms? I don't actually see super heavy livers frequently in practice at all, because I find I'm working with people who are generally on the healthier side and want to stay healthy and are working towards being healthy and staying healthy. But you will come across people where the liver does feel really heavy. And then you kind of got to go back to your history as to why that might be, and assess all of those qualities. Like, is there congestion? What's going on with the diaphragm? Is there a history of severe whiplash where maybe we've lost that extensibility in the tissues, especially the coronary ligament, etc.? Or not lost the extensibility, it's just increased too much. It's too loose now. So anyway, so these are all things that you can start playing with now that you've listened to this lecture. So I'm going to stop sharing my screen, and then we can move on to the next one. Sorry, guys, I'm just having a hard time with... There we go. Now I've got that. Okay, well, I hope you have enjoyed that lecture on the liver, and we'll see you soon.